Okay, our next speaker is Dr. Michael Noseworthy. Michael, many of you know Michael from all the development he's done in the area of imaging. He is currently the Associate Professor of Biomedical Engineering at McMaster and Director of Imaging Research Center, which is a federally funded through CFI center at St. Joseph Hospital. Michael has been working with us in developing new MRI technologies, and he certainly was very instrumental in some of the work done in the Canadian company Sentinel, which is now increasingly become recognized as one of the leading companies in the field. His research interest focuses on assessment of tissue microstructure and metabolism using magnetic resonance imaging.
Good to see everybody. Thanks a lot for inviting me here, Dr. Anvari. So, yes, I do imaging. That's what my passion is. I've been working in the area of medical imaging for 22 years now. And I've been developing lots of interesting new algorithms, hardware, software, etc. for imaging inside the human body and other things too. But I won't talk about the other silly, sometimes fun things we do. But I'm just going to talk about the human body. But one thing we all know, we've seen many images radiologists have or physicians have, MRIs, CT scans, everything like this. One of the things I'm very interested in doing is taking data from multiple modalities and merging it into one common platform, and not just giving information of structure, which most radiologists and physicians just have. They'll say, oh, there's the tumor. Okay, well, we have to do whatever A, B, C, D. My real passion and the direction in my lab, one of the directions, is actually taking multiple modality information, but not just structural information, but functional information, metabolic information. What part of the lesion or the disease is actually active? Okay, that's what I'm very, very interested in finding, because if we can find or target the active part of the lesion, we can maybe biopsy the lesion, or we can focus our therapy on that very specific center in the lesion. Okay, because what you don't want as a patient going for an interventional biopsy, let's say, and the physician comes back and says, we kind of missed. We'll have to do it again, okay? That's not what you want to hear. You want to hear, you got it, okay, and we're going to go ahead with what we have to do next, okay? So that's what I want to definitely focus on. So my talk is functional multimodal imaging, definitely different modalities coming together, and we have lots and lots of different things we can actually use in terms of medical imaging. So on the functional side, as I said, we can get lots of anatomic imaging, but functioning tissues is really what I'm trying to focus on. So, for example, we have this is from one of a very great textbook by Peter Jezzard on functional MRI. We have functional MRI kind of sitting here in the middle of this chart, which talks about the level of the size at which we can see functioning things, how invasive it is, et cetera, et cetera. So we have lots of different modalities we can look at function. Some of them have better spatial resolution, some of them have worse, some of them have better time resolution, some of them have worse. Some of them are not invasive. Like MRI, for example, we call it a non-invasive technique. In 22 years, I always tell people, especially patients, I think I've been scanned about 1,000 times in an MRI. For all kinds of reasons. I've had IVs in me for research. It doesn't matter. I'm really focusing on trying to develop a technology, and it's a non-invasive technology, MRI. It's just radio waves and magnetic fields. So really, I say it's safe. Okay, I used to be taller. You know, my hair was black. You know, no, I'm just kidding. It's as far as we're aware, it's fairly safe technology. There's no X-rays associated with having an MRI done. So it's nice to use that kind of a modality. We can do it repeated over and over again on the same patient to look for, let's say, changes that may occur. Okay, so we don't have to worry about doses of X-rays or whatever. So I'm going to talk for the very first part of my talk about functional MRI, because that's kind of like the start of how it all really is coming about in terms of functional imaging. So I've done functional MRI clinically for many years, and that is this is sort of like a main staple for psychologists now, where they do functional imaging to find out what's activating in the brain. But you can use this for a very great way in surgical planning, which I've done a lot of. Now, what functional MRI is basically how can you activate the brain and find it in the brain? And you can think of any way you can activate the brain, from motor to sensory, memory, whatever you want, and then look inside the brain at where that activation is. And just the typical MRI setup might be an MRI and maybe some headphones and some button boxes and things like this to get the people to respond to various stimuli. So, you know, anything you can think of to activate the brain, we can map it. which is kind of exciting. And this is kind of what happens when the brain activates. The brain actually is a very greedy organ. It says, give me 5 units of oxygen when it really only needs 3. The blood vessels in the brain dilate. When it activates, you get a big rush of oxygen in. It's greater flood of oxygen into the brain area than there is actually metabolically needed. And you get a change in signal. And then we superimpose statistical maps on top of brain images to look for where the changes are actually occurring. This is contrary to EEG, which is very this is something that's hemodynamic, so it's looking at the pipes in the brain. So it's a fairly sluggish technique. It takes a few seconds for these things to actually occur, not like EEG, which is in the time frame of milliseconds. So what we do with the functional brain imaging is we take some nice, beautiful anatomic images of the brain, and we'll do a few hundred of those, and it takes about 5 minutes. And then we do what's called BOLD imaging, or blood oxygen level dependent imaging, and this happens very fast. Typically for whole brain, it's about 2 seconds per entire brain volume. So we'll do this repeatedly over and over and over again to build up enough statistical power. And then we'll do some sort of analysis that could be something like, let's say, for example, a cross-correlation analysis. So here's some real data with this red line in here is some sort of an ideal waveform we're cross-correlating with, and we'll show where some activation is in the brain. Or we can do something like, this is from Jody Cullum at University of Western Ontario, just a simple statistical t-test, where it's activated and where it's not, and superimpose a statistical map on top of your high-resolution map. Okay, that's really great. And I've done many functional MRIs. I mean, it's fairly standard technique to do, and my passion for this is in the clinical side of things. So here's a good example. When I used to work at Sick Kids, I did functional brain mapping for neurosurgical planning every week. And the idea here is someone with a brain tumor, okay, they seem to walk in okay, and everything looked okay. You look in their brain and you go, well, where's that motor cortex gone? Because it isn't there. There's a tumor there now. So the brain motor cortex is somewhere. Let's give the surgeon the information on where not to cut the brain when they have to go in. So this is one case here. There's the motor cortex here on the one side, and this 13-year-old boy that I measured. Here's the tumor right here. There obviously used to be a motor cortex there. It's been shoved somewhere else in the brain, and in this case it was pushed up a little higher above the tumor, so the surgeon knew not to go through there because he'd cut the motor cortex, he'd eliminate function of motor in that side of the brain. So that's really, really a useful technique clinically. Does it work? It really does. I mean, I've been involved in neurosurgical procedures before. Here's an example of a case we did at the IWK Hospital in Halifax. It's a meningioma right here, and that's the surface of the brain. The tumor is actually this. And plot out exactly, we did the functional MRI beforehand, and using a neurosurgical stealth system, find out where we actually correct. Excite the surface of the brain right above the activation. So this is an activation right here for language, and one here for motor. The person's awake for these surgeries. They're doped up, they don't really care, obviously they don't really care, their head is opened up. And you ask them to do different tasks, and they actually perform them. And you do things like count to 10, and they'll start counting, and then all of a sudden their speech goes a little wonky when you excite the surface of the brain. So we were bang on. It's a very, very high accuracy technique, and the surgeons can actually then go in and do very, very good surgery, avoiding the areas that are very, very critical. It works for all kinds of different activations. And I've done many, many of these, and I'm very, very confident about doing these kinds of studies. So, I've done that so many times, and I'm the kind of guy, I always like to be challenged, okay? After a while, I got really I love doing the head stuff because it's very, very powerful, useful for patients. But I want something that's going to drive me crazy, okay? Something that's going to make me really think. So I thought, well, let's move into the body, because the brain brain is easy for me to do. It's a sphere, it works well. Whatever, okay? It's a nice, simple technique for me to do clinically. Okay, I won't say that to psychologists. They'll think I'm crazy to say it's an easy